to share this time with my colleague Alexander Vlaar from the Netherlands. My name is Federico Pappalardo. I'm from Italy. So, Alex?
Yeah, so very nice to be here. But maybe before we start, there can be, of course, different topics we can discuss. So it's also a bit of free for everybody to say where we're going to talk these 30 minutes over. But maybe to get a bit of a feeling for us, but maybe also for you, who is sitting here while already running an ECMO program? Yeah, hands up. Okay, so that's about, I think, 40%, something like that. VV ECMO. It is VA ECMO. We can also, sometimes there is another V coming in with VA ECMO, so we can go there. Or if VV turns out to become a VA. But who is not yet and wants to sit here and really like to learn how should I start up a VA ECMO? So there is one hand, another hand. And the rest is just trying to find a chair to sit for 30 minutes, or yeah, okay. Yeah. So maybe the people who are already having some runs, because I think that was the majority of the hands. What are the struggles you think we are facing now in ECMO and we should discuss here?
So first of all, my question is, this is supposed to be an ICU community. So who is here in this room the lead of the ECMO program?
Who's in the lead?
Okay.
Yeah, so one. So yeah, I think also in your side. The ICU, yeah, so not as in person maybe, but more is in your side the ICU in the lead, or are it the surgeons, are the cardiologists? ICU.
ICU. Do you just have ECMO as an MCS, or do you have all platforms for mechanical support of the heart? Just ECMO. Okay. So
there's more. All.
All.
Yeah.
Who's got all? Tandem heart, Impella, balloon pumps, lava, ECMO, whatever. Okay. So who is doing ECMO alone? So who is treating patients with cardiogenic shock just with ECMO alone?
Yep.
Okay. Alex, what are you doing with your patient? Are you still using ECMO alone?
Well, this is of course an interesting field now. If you are focusing on whether or not we can treat the patient alone with ECMO. In many cases we do, but I think we differ here. So that's also nice that in an expert setting there are different approaches. If a patient on VA, we do see ballooning, or we do see that an aortic valve is not opening anymore, then we either add an Impella or we put an IBP balloon pump in. But it's really personalized, so it's not that we do it as a standard of care. But what's your opinion on that?
I think that mechanical unloading is necessary, 100% of cases. I would suggest that I mean, if you look at data, you know that I have personally generated the data about the Impella concept, so I'm a little bit biased. But I would say that every patient should get a mechanical unloading device. Either it's a balloon pump or an Impella. I'm very much against the surgical strategies. Because of course they are more invasive, more bleeding. More,
and maybe for everybody surgical, you mean a left vent?
Left vent, LA vent, or central ECMO. So this is something which is, I mean, putting the patient at risk for bleeding. It's disrupting the heart anatomy if you're looking for a future upgrade to durable LVADs. So I think that balloon pump and Impella have, I have a role. I do see that the role of Impella is broader in terms of the opportunity to save the heart, the native heart, and to de-escalate. So to have a very short ECMO run and then to jump just on isolated left side support.
So, but then I think what an important issue is here also It is observational data. It's propensity matched. The circulation paper shows data which are very promising. On the other hand, I think it was Jama looking in cardiogenic shock, so not ECMO, IABP, so balloon pump versus Impella. Impella was worse. A lot of problems, a lot of complications. Then the other thing is, of course, we also need to think about where are we putting our euro or dollar. I don't know who is in the audience. The Impella is, I think, about between 12 to 15,000 euro. A balloon pump is just, a fraction of it. Yeah. The evidence is quite, well, if you would go to a guideline, it will not reach the highest status. So if you put that together, it's quite strong to say 100% needs to be unloaded. So what's your reaction on that?
Yeah, first of all, I have to remind that the data that have been generated about unloading were mostly about patients who had a primary isolated left-sided support. So if you look at the ELSO registry paper, 80% of patients were first on a balloon pump or Impella and were escalated to ECMO. So this is a paper which has been named Unloading ECMO, but definitely it's escalating balloon pumps and Impella rather than unloading ECMO. The other point is about timing. Of course, there is a lot of rationale behind waiting and looking for the overload to take place. But on the other side, data tell us that the earlier, the better. So it should be, according to the publications available, within the first 2 hours after starting ECMO that we start the unloading. On the other side, if we wait for having the signs of overload, that could be too late. Practically speaking.
But then, just straight to have a question, what is for you a sign of overload? Do you use ultrasound? Do you use Röntgens? Do you use imaging of the lungs? What is your what's your trigger?
So we use first of all arterial tracing. So if you have ejection on the tracing, it means that you have some amount of ejection from the left ventricle, and there definitely echo and chest X-ray. So in putting together this data, you can have a consistent idea about the hemodynamic equation. It's very important to remind that when you start ECMO in a patient who is suffering from acute LV dysfunction and cardiogenic shock, the first mechanism that you activate, it's LV unloading by unpreloading of the LV. So if you look at echo at the very beginning of the ECMO treatment, you will see your ventricle doing a little bit better, because at that time the unpreloading effect is more prominent as opposed to the overload which is coming from the retrograde flow. That's why you have to be active in looking for these signs, because at the very beginning you might miss it. And that's why I recommend to have continuous monitoring of the echo.
Yeah. So, and the other thing is, I think still, I would go still for a randomized trial. In the Netherlands, a randomized trial is starting. I think in Germany, it's also running one for ECMO and Impella. In the Netherlands, it will be balloon pump versus. Because I think there is potential still a bias in the observational studies. If I speak for our center, sometimes we have, for example, an eCPR or a cardiogenic shock, and in the heat of the moment you put in the ECMO, and then suddenly you get some more information about the history of the patient, and then you think like, why did we put an ECMO in? And then we decide, okay, we will not go for additional unloading because we think it's the patient needs to be able to do it with this, and that's it. This bias is very difficult to get out of the observational studies.
So you mentioned a very important topic in this regard, which is the concept of the heart team. So who is taking the decision, especially if, as we are in an ICU community, and those of you who are doing ECMO, I guess they are mostly doing ECPR cases, I guess. So who is taking the decision to put an ECMO in a patient under cardiac massage coming from outside the hospital? And what are the gaps that you see in your practice to be filled in terms of medical evidence, technicalities, capability to cannulate, whatever?
Cardiac surgeon, and is making the decision also. Okay.
Okay.
And what are you doing then?
I'm intensivist, so I contact the cardiologist, and he come and he check the echocardiography, and he call the surgeon, and they discuss and they decide to insert the ECMO and unloading device such as IBP and impeller together.
So, and who is taking everything like balancing? Is this patient going to benefit? Is it a good case? Who is getting this information and this decision?
Cardiologist.
Cardiologist.
Who's that?
So-
For other sites, maybe different.
Yeah, different practice. So a patient is coming from from outside of the hospital, cardiac massage, witness cardiac arrest. Who is taking the decision of ECPR?
Maybe first, who's doing ECPR?
Yeah.
Yeah. So who?
Okay.
Hi, Czech Republic. Decisionist in our practice, there's always the person who run or lead the cardiac arrest team at this day, and he's always contacted from the terrain. So decision if the patient is suitable for the ECPR is made on the telephone just on outside today.
Yeah. Which specialty?
I'm intensivist too, but the head of the cardiac arrest team is always cardiologist.
Other sites?
Other sites?
We have a protocol,
Which center?
Copenhagen,
Okay.
and so decision is taken before patient is came to the hospital. But my question is, what's your limitations to put patient to via ECMO if it's ECPR?
Well, I think this is a very hot topic. I think there are now 3 randomized trials out there. So we've got the ARREST study from the US in Lancet. We've got the Prague study in JAMA, and we got the INCEPTION just from the Netherlands. I think what it shows, well, that's my take on it, and please give your input. In the US study, they show if you have the perfect circumstances and a very selected patient group, you can have great results. The other thing I think which is very important to compare is what's the baseline chance of surviving an out-of-hospital cardiac arrest in this area, because, for example, in the Netherlands, it's above 20%, while in many countries worldwide, it goes to 2 or 5%, your baseline survival. So this may result that per country there is a different effect of an ECPR program. I think the Prague and the Inceptions are a more real-world setting. So if you put it in the normal infrastructure, or you put it in several sites, you will be confronted with also the real world, where you might want to have your patient within 1 hour on ECMO, but practically it's very difficult. So we have criteria below 70 years. It was for before the inception, witness arrest, first rhythm, either VF or shockable, or PEA with a suspicion of pulmonary embolism or an intoxication, and within 1 hour start of ECMO. That are our criteria. Tomorrow, the day after tomorrow, we have multidisciplinary. So in our hospital, we really do it as multidisciplinary, like cardiology, perfusion, cardioanesthesiology, ICU, cardiac surgeons. Everybody is involved in the program. In the decision, there is the ICU. ECMO team is in the lead, because somebody in the end needs to make a decision. But we really do it in the end together. And together we are also going to evaluate the results of those 3 trials and to decide what are going to be the new set of rules, which will probably not be more liberal, but more strict.
So 70 years and how many minutes?
60 minutes maximum. But I do not know yet the results of our decision. There are some of my colleagues here also, but we probably will go in a shorter time frame, and also with a younger age. The other big question mark is, of course, should we put the ECMO already outside the hospital? on the street. So that's another program now going on in the Netherlands, is the on-scene trial, where the helicopters are being step-wedge randomized for having an ECMO on the helicopter versus areas without an ECMO. And there we will see whether shortening these low flow periods is improving outcome.
But who is in this room calling for randomized trials in refractory cardiac arrest, so to validate the ECPR? Okay.
Who is against? Why?
Because I think that the cemetery is for sure, on the other side, the control group. So I don't think that there is the need to randomize a patient to the cemetery or an attempt to resuscitate.
That's interesting. It's an interesting remark.
As long as you have the resources to do that, there is no sense to randomize a patient who's more than 15 minutes after cardiac massage. We know that the prognostication is 0. And these trials, which have been published, were very, interesting, because as usual, they have destroyed the technology that we have in intensive care medicine, should be read from the other side. So look at control groups. Not a single patient survived. So these trials are useful not to validate ECPR, but to be on the safe side, stating that if you have refractory out-of-hospital cardiac massage and you have no ROSC until hospital arrival, you are dead.
Well, that's interesting, because that's, I think, one of the eye-openers of the inception, but maybe you...
Yeah, I must disagree with him. We have a great program, ECPR, out of hospital, in hospital cardiac arrest. We made the program so that our doctors are already on the emergency cars. So when is a cardiac arrest, is the emergency doctor, and the ECMO team is parallel to the scene. So we had for a couple of weeks, 50 years old, he's in refractory cardiac arrest. 15 minutes, I think, we were on scene at 7th floor in a bureau building. ECPR on the scene, the person went in rehabilitation on neurologic problems. And it's not the only one, also for cardiac arrest, for lung embolism, there was the same thing. 30 years old, on screen, in the bus, I think we cannulated the guy in the bus in our city. I think 2 weeks after, he went also in rehabilitation on a neurological problem. So it's only a matter of time.
Yeah, that's why I'm asking you, would you randomize such a patient still to conventional CPR? That's the question.
Well, I think the issue is you will always remember those few cases that do well. And coming back to the inception, what was surprising, and that's one of the reasons why, although there is a difference, it is negative and it's the intention to treat. So we also need to see the per protocol, which will follow. But what the interesting is that this control group, after 1 hour of CPR, has still a higher chance than expected to recover. And this is also what we were faced, that sometimes we had 2 patients at the same time and we were not able to put another ECMO in because the team was already running the cannulation on the other side. And this patient would have had an ECMO, but it had ROSC after 60 minutes and recovered fully. So also without ECMO, so I can tell the same heroic story, that a patient after 60 minutes with conventional CPR had just ROSC and fully recovered. So this is my claim why we need randomized trials, because we have this observation bias that you remember this case that did well, and then you think it would never survive without ECMO. But just to challenge you.
We had also a patient with 3 hours reanimation with short periods of ROSC. He also had an impeller running, and after 3 hours of reanimation until our ECMO team was deployed in that hospital, went home without any neurological complications. He was even ICU and everything is fine.
Yeah, that's why when the criteria for enrolling in ECPR are asked, I think that if you have any kind of intermittent ROSC, that patient is definitely to be cannulated. So we are discussing about the patient who has not a single a single ROSC under mechanical cardiac massage. If a patient has ROSC, that patient is the patient who has the higher chances of survival with neurological good outcome. So definitely intermittent ROSC is an indication for ECPR.
But I think we do not have a discussion in the end whether it works or not. I think we all agree it works. The question is which patient group benefits most and how to identify them. And in the end, it is a question of resources. How much money do you put in this one patient compared to your ICU bed for an elective post-operative patient or another patient? Maybe another question, the cannulation strategy, because I think this is an area where there are some studies now, still observational. I think we need also more evidence, maybe randomized. We will try to support that. Whether we go for a surgical approach, whether we go to a percutaneous approach. Who is doing a percutaneous approach for VA? So I think the majority. Who is taking surgical approach?
It's a question. Yeah, it's a practical question. I'm from Portugal, and a practical question. How many attempts do you try ultrasonographic access before surgical access? We start always by percutaneous cannulation, but we try once or twice. I'm asking about ECPR, which is sometimes very difficult with Lucas and all the sequences. But I would like to know how many attempts or how many time do you spend before surgical approach?
Okay. So we always cannulate percutaneously. At the beginning of our experience, there were some cases of cannulation failure, but I think that at the end, the surgeon is not very much helpful in this regard because it takes time and they usually open, which doesn't make a lot in terms of effectiveness, so, or I would say ability to find the vessels. If I have to call for someone, I call the vascular surgeon, who is very much able in doing some tricks percutaneously. We never use echo here, but it's mandatory that you have TE. There is not a single cannulation without TE. Never use echo in the groin.
Why are you not using echo?
Because it's a matter of time. We puncture very fast, and if we see that the guide wire is in the right place, we go for we go ahead.
Okay.
Because descending aorta and bicaval view. It's the only thing that allows you to push, because then you have to push.
We started with surgical because we wanted to have 100%, near 100% success in the starting of the program. But on the other hand, you need to have a surgical team who is willing to do it. And now we are changing to percutaneous and starting a trial, a randomized trial between the surgeons and the percutaneous team on success, speed, all those observations. So, yeah, no?
Hi, I'm Yoel from Tel Aviv. I actually have a question about another complication we see a lot with the VA ECMO, especially the ECPR. These patients come after a long period on either manual compression or Lucas, and a lot of them start bleeding. And that bleeding, once you have the cannules in and anticoagulation, it's a huge problem to manage. In our institution, we actually started to do fast exams right before cannulation, because if we already see that the compressions caused significant abdominal hemorrhage, we avoid cannulation. Is that something that you also encounter?
Yeah, that's a very interesting question.
Yeah. Yeah, you want to respond to that?
We saw it when we used the auto pulse, which is with these bandages. Then we saw it, but we do not see it frequently with Lucas.
So we now and then see it, like a liver bleeding, for example. We see it during the course. If it depends, I think, also on the type of the case, whether you would go for an additional intervention or whether you think this is a bridge too far to cover. Okay.
So just a comment. I think it's very important that you never give heparin or anticoagulation until you are sure that you have not ruptured anything. So what we do is we cannulate, then we check, and as long as we are sure that there is no bleeding, then we give heparin or anticoagulation.
I think this is also a movement. We were very afraid of thromboembolisms during ECMO, and actually we are now more afraid for bleeding. The coatings of the systems have been improved, the techniques. Walter is running also with the Dutch ECLS now a randomized trial on different anticoagulant strategies, whether we can really lower the anticoagulant target. So hopefully this will give also some insight there. Maybe another question. We started with, well, a bit in the ECPR. We've got the placement, but the removal. How are you removing your VA cannulas? Who is doing it, just compressing very hard and very long? You're doing it?
We started to do, we used to do it surgically, now we are doing just compression for 1 hour.
And how does it work?
Very well.
Yeah, no problem?
No.
Okay.
It depends on the patient, how the size of the patient. Okay, if we have such a really big patient, then we are doing surgical. If the patient is normal, then we are doing with a femur stop.
Just compression.
Only compression, yeah.
Now we are trying to do the artery with, for example, Manta system, and vein with just manual compression.
And who's more doing a Manta or, yeah? Yeah? And are you doing it in the ICU then, or are you going to the intervention room? Cath lab, ICU? Yeah.
How long does it take to do a Manta procedure? Few minutes. Okay, how many operators? 2. Okay, what is the usual arterial cannula size? 17.
And
Okay.
what's your approach?
We always compress. We did some percutaneous closures, but at the end it took so long. 3 operators, you have to do the rewiring, and then the Manta has some failures. I mean, we never do pre-closure because, of course, it's an emergency case. So we did some cases, but at the end we realized that it doesn't give you so much of benefit in terms of resources, and of course the Manta device is very expensive as well.
So, and how much time do you take for compression?
Depends. Yesterday we did 15 minutes.
Okay. Okay. So I think these are interesting topics. Maybe another thing is LECMO. Is this something everybody is using standard, or are you?
I want to ask a question. If patient with the intubation, impeller, ECMO together, which device do you remove first?
So our approach is to win the toxic. So first toxic, inotropes. So not a single patient should receive inotropes during mechanical support. Then tube, then ECMO, and very last impeller.
So who is doing awake ECMO without tubes? Half, sometimes, depends.
Yeah, of course.
Whether it's a cooperating patient or not.
Yeah, I mean, if you have cardiac arrest and the patient is suffering from neurological injury, you cannot do that. But the strategy, I always call, it's important to have the strategy. So what is the institutional approach? Then, of course, you have outliers because, I mean, we are doing medicine and not mathematics. But as a strategy, the strategy is to not have inotropes, not to have the tube, not to have the ECMO, and lastly, to remove the impeller. But, I mean, this is the strategy. So that I call it the super simplified protocol. So if you want to have an effective MCS program, it has to be 24/7. And 24/7, the people who are there have to keep the direction. And this is direction. Then there are details, but the direction has to be super simplified, I think.
Yeah. Are there questions or topics we can discuss, I think, 2 days here about VA ECMO? Are there?
Yeah.
Yes.
Yeah.
Again, when you put a patient to ECPR and ECMO, so do you consider what the value of pH and kalium, potassium?
No.
No, so we do not look at that. Only for drowning. There you have this Alaska score. It's a US score. There is potassium in, and I think lactate and age of the patient and gender. It seems also a gender factor to be there. But in ECPR per se, we are not looking at that.
Yeah.
The reason, yeah.
Sorry. So no, finish.
No, maybe. We will start because in 2 days we have this, the whole group meeting in our center, what we should change in the criteria. So it could be that you have end-tidal CO2, some of the protocols use it. That's maybe an easy to go to, but for example with pulmonary embolism, what's your criteria then? The other issue with lactate and with potassium is you need to wait for the test results while you're actually losing time. So, and then this is the danger, of course, with cases. We have the patient with the highest lactate, which recover. So
you cannulate artery, so you have results at the same time.
No. But our policy,
what's your take on it?
So our policy is that no one should touch the groin except the cannulator. So there is the policy is that you should not attempt to do ABG on the femoral vessels, because then you can have a disaster when it's time to cannulate. And I can tell you that I would not bet a single euro if what these guys are examining, it's venous or arterial, because many times you don't understand. That's why we use TE, because the only way to understand that you are in the artery is to have the guide wire here. Sometimes when you puncture, you don't know where you are. You go with the guide wire and you say artery, vein. That's the only point. So if you take an ABG, could be venous 80% of cases. So I think that methodologically, this ABG story is not reliable. So
don't misunderstand me. You cannulate a patient, you've got a cannulation cannula, and so you will have a look, and so this is the artery, you take the blood gas.
yeah, and then you stop.
Yes?
No.
This is 6.5.
Well, then it's maybe another question: who has a donation program also coupled with the ECPR? Because so if a patient has a poor outcome, it can be an ideal donor.
Yeah.
So in that way, if you stop already at the beginning, you lose also donor potential.
Yeah, that's why the trials have not addressed the very final question, which is about the people who are surviving with ECPR intended to be, let's say, cumulative endpoint of survival or organ donor. Because at the end, I think that you can be more liberal if you have the organ donation program. If you cannot have donors, then of course it's reasonable that they are more restrictive.
Yeah.
Okay.
I think we're already over our time slot. So if there is no more urgent question, we're going to finish it. I love to have this discussion and hope you have a great days here at the conference.
Thank you. Thank you.